Yeah. So now something about the cholesteatoma. Are you getting the slide? Boss, are you getting the slide?
They're getting no boss.
Okay. So there are a lot of controversies in the cholesteatoma in terms of decision making. स्लो कैसे हो गया यार? Why this is not, yes. Yeah. So this is about decision making in cholesteatoma surgery. So there are few concepts which we have over the period of years found, going to the literature, talking to the experienced people, experiencing ourselves, and in our series and our follow-ups which made us reaching to this level. So the most important thing in middle ear surgery, for anything like we discussed during tympanoplasty that time as well, the concept of middle ear cleft and the aeration. And this work is most extensively studied by none other than Jacob Sade, who is the father of Eustachian tube surgery, Eustachian tube physiology. Silent karo.
Raju, can you unmute everybody so that background noise should not come?
दिनेश सुता रहता है क्या? दिनेश को फोन करना, म्यूट करे. म्यूट करे. हेलो. वो गया. प्रॉब्लम है. Yes, yes. Coming. Hello, can you hear me, sir?
It's okay, now it's okay.
Yes.
Okay. So this is Jacob Sade's work, which has done a lot of work on the Eustachian tube physiology. So according to him, this middle ear cleft is like a lung and tracheobronchial system. In the sense, the middle ear is like a gas pocket where the gas comes in from the Eustachian tube by intermittent opening of the Eustachian tube, and from the middle ear the gas is absorbed continuously by the mucosa and its blood supply into the blood system. So the constant absorption of the air leads to negative pressure, and which leads to intermittent opening of the Eustachian tube to neutralize that negative pressure. That's how the physiology runs. So, coming to the cholesteatoma, as I mentioned, there are a number of procedures described which are good enough to confuse everybody. Take canal mastectomy, canal down mastectomy, then intake canal mastectomy with obliteration, canal wall down mastectomy with canal reconstruction, canal down mastectomy with cavity obliteration, epitympanoplasty with obliteration. Whatever you can name, you can. And number of these are very few. Now the question is, what technique is the best? And mainly there is always a, discussion in the conferences. I don't know why. Intake canal is best or canal down is best. To me, this terminology has to be renamed for the reasons I am telling you. Number one. And number two, intake canal and canal down, both techniques are best. Issue is, they are executed properly and they are done properly for the proper indication. If the intake canal is done for a wrong indication, it cannot work. And then people will blame the intake canal. You see the literature, people will mention, I had been doing intake canal for 10 years, then looking at the recurrences, failures, I changed to canal down solely. Then you will find literature, people quoting, had been doing canal 1 for years, but because of the continuous discharge, repeated cleaning required, hearing issues, swimming issues, I have totally changed to intact canal. It is not the intact canal or canal wall which is to blame. The thing is to properly execute the procedure and to properly execute for proper indication. That is more important. So our terminology for them is interiorization and exteriorization. Why so? Interiorization means what you call intact canal mastectomy, wherein you reconstruct the physiology of the middle ear cleft again, wherein the aeration comes through the intact eustachian tube and there is mucosa inside for the gas exchange to maintain the middle ear pressure. That is how the normal physiology works. That is interiorization. Provided, it can be done? Provided the eustachian tube function is normal and the adequate mucosa is left in the middle ear cleft after the surgery. This is important. Then only interiorization can work. Got my point? Suppose your eustachian tube is intact and during the mastectomy and entire disease removal, you happen to remove the entire mucosa of the middle ear cleft. And now you reconstruct interiorization intact canal. What is going to happen? This will be akin to blowing the air in the bony trumpet. It is not going to work. Even if your eustachian tube is delivering air, where the air is going to go? There should be mucosa for the gas exchange to happen. And in that situation, interiorization will not work. So when interiorization is planned, you have to be sure about the good eustachian tube function. At the same time, reasonably good amount of mucosa preserved. That is one.
Is there something as a good amount of mucosa?
That's what I'm coming to. Yes, Ashish, your important point. Good amount of mucosa means the mucosa on the promontory in the middle ear and in the atic floor, which is most importantly used for the gas exchange. Number 2. Now there are so many techniques named here. Intact canal mastectomy or a canal down mastectomy with canal reconstruction. What is it? You have done a canal down and you reconstructed the canal and again did a interiorization. Though it was canal down, but it is interiorization because again you are reconstructing the cavity on the basis of eustachian tube function and the mucosa for the gas exchange and reconstructing the physiology. So anywhere you are reconstructing the physiology, whatsoever you are doing, canal down mastectomy with soft wall reconstruction, anything, this comes under the category of interiorization. Other thing, when your eustachian tube function is at question, when you at the end of the surgery you have not left with the adequate mucosa to give interiorization, then the best is to exteriorize. But once you exteriorize, mind it, you don't have eustachian tube to deliver air for your mucosa to function well. In that situation, you have to exenterate all possible mucosa to prevent mucoseals and discharge. So, once you are doing exteriorization, you have to exenterate all dependent cells. Once you are doing interiorization, you are not supposed to exenterate all cells. You just remove your disease, preserve your mucosa and reconstruct. That is the basic difference. So, both the techniques are good in the sense, if they are executed properly. If I am doing intact canal, I will be very sure on the table that my eustachian tube function is good and I have preserved adequate mucosa for the gas section, then only I will commit. At any point of time, I find this is not good for interiorization and I am lacking the mucosa or eustachian tube is a question. There is a lot of adhesive otitis media and all that. The eustachian tube may not be good. I will not do and then execute properly a exteriorization. So all these examples are exteriorization. Epitympanoplasty with obliteration. Intact canal mastectomy with obliteration. All these are exteriorization. You are eliminating the mastoid. You are exteriorizing. You are not making it, keeping it dependent for the eustachian tube aeration. Now, why this question came? The canal wall up and canal wall down. The reason is, by and large, there are certain advantages of canal wall up which make us biased to do a canal wall, because it reconstructs the normal physiology of the ear, normal contour of the ear canal. Contour is maintained, you can use a hearing aid better, your hearing outcomes are better as you have a good adequate middle ear space, and overall quality of life is good, which is not in the canal wall down. In canal wall down, you end up leaving an ugly ear cavity. You cannot swim, you cannot recommend patient to swim, hearing aid is difficult, hearing outcomes are overall poor because you end up leaving a shallow middle ear cavity, and overall quality of life is poor. So that is the basic difference. Now, other differences if you look at, which make us biased towards intact canal or canal down. Let's go to enumerate them. So, what is it? Why people are moving towards a canal wall down? Why do people say canal wall down is better? One of the reasons is access to the difficult areas of middle ear. They believe that they can access entire temporal bone areas, important areas with a canal down, with good access. Believe me, any area of the temporal bone I can access through the intact canal. First of all, number one. Number two, if I am not able to access to the intact canal, I will bring the canal down and reconstruct it again. But that procedure will remain interiorization. That's my point. Provided it fulfills the basic criteria of eustachian tube function and mucosa. So there is no question of access to the difficult areas through the intact canal, by means of thinning the canal, by means of temporary removal of the canal, by means of making window in the canal temporary, you can access all areas. So this point is not very well taken. Second is, one of the biggest drawback of the canal wall, what people who used to do earlier and now they have given up, is the recurrence, the possibility of the recurrence. Because you cover everything, you never know, even if you have left a trace of cholesteatoma behind, it is bound to come back, and that is a disaster. So, for all those patients, when you are recommending intact canal, it should be a part of informed consent that they may have to undergo a second look procedure. Then only one should do an intact canal procedure. This is mandatory for those who are doing intact canal to recommend their patients, because you are giving them a good quality of life, but at the cost of need of a second look, a close follow-up. That's why those people who are not able to come for a close follow-up, like from distances, from villages, who are not committed for the lifetime follow-up, it is not better to do an intact canal procedure. It is better to do a canal down, execute good canal down. I tell you, if you execute a good canal down surgery, it is wonderful, it gives amazing results. It is the fault in the surgical techniques once you do a canal down, which leads to problem. So, when there is a possibility of a revision disease, it is always remain in the canal down. That's why canal up. That's why a possibility of the second look is always should be in the consent process. Then revision surgery required. Yes. These are the advantages of canal wall up, that water exposure limit. There is no limit, no vertigo. It takes, the cavity heals very fast. Frequent follow-ups is not required, unlike canal down, because the cavity problems are there. So why people are, try to get away from canal down, why people look for the canal wall up, is only for the cavity problems. So if you tackle it both ways, one is, if you don't leave a big cavity to give cavity problem, yet you can do a canal wall down and one-time procedure to avoid a second look. At the same time, if you execute even a good cavity, properly, marsupialized cavity, properly epithelialized cavity with a good vascularized tissue, you can avoid cavity problems. So it is not, my point is, it is not a question that which technique is better or which technique is worse. Both techniques are good. They have their advantage and disadvantage. That's why people are switching from one to other technique, considering that this technique is not good. So what is our protocol? It is never a pre-operative decision what technique is to be chosen. Number one, you cannot commit to the patient what technique you are going to do. This should always be an intraoperative decision, except some, exceptions, which I'm going to tell you. Like, for example, we did that day, CSOM with facial palsy case on Thursday. We were biased from the beginning to do a exteriorization. The only reason was, it was a small cavity. On CT scan, we saw the area where the mastoid was hyponeumatized, very small mastoid. So in that situation, we are biased to do a canal down because we can avoid all cavity problems. And at the same time, we can get away with a single procedure to prevent the need of future surgeries, which is required in a, second look in a intake canal procedure. So there are certain things which makes you biased towards the intact or, canal down. And one of them is size of the mastoid, which is certainly, I always want to do a canal down, if you ask me. Except, I will do intact canal only intraoperatively when I find a good eustachian tube function likely and a good mucosa left at the end of the removal of the disease. Only these two will make me do intact canal, otherwise all canal down. Exteriorization. Except again some situations, like for example pediatric patients. Pediatric with a pneumatized mastoid, you are not supposed to give bigger cavities. You have to reconstruct the hearing as well. Pediatrics are more demanding. They are not going to follow the rigorous cavity care and all that. And you have to be biased towards intake canal procedures or interiorization. Right from the beginning. Now in those situations, intraoperatively if you find, even if you are biased preoperatively, that you have not left the adequate mucosa and eustachian tube function, it has question because of the nasal issues, other eustachian tube issues, better to do a canal down. So preoperatively, biasness should not follow strongly intraoperatively. It is finally the intraoperative decision, which is the finally decision. And the third procedure we do, we have the case next to it today, is the subtotal petrosectomy in blind sac closure. That is ablation, complete ablation of the middle ear system. That means that is required for only those situations where the reconstruction of the middle ear is not possible for the hearing. And patient at least can be given a dry ear for the future problem, to prevent future problems. Then is the final solution is the subtotal petrosectomy and blind sac closure, wherein the entire air cell tracts of the temporal bone are removed, preserving the labyrinth. Close the eustachian tube, close the outer extraordinary canal, remove all mucosa and epithelium from everything. And in that cavity, you obliterate with the fat or something to give a sterile environment to prevent future infection. At least you can give a dry ear to the patient to prevent the need of future coming to hospital for discharge or anything. But only those patients wherein there is no question of reconstruction of the hearing left behind. In those patients still, the possibility of cochlear implant in future remains intact. If somebody wants to get implant done, it can be done at the same stage or even in the future. Suppose the patient has not done the cochlear implant yet, you have done a good subtotal petrosectomy obliteration. Patient wants to get done after a year or so. You can take the patient, open, remove the fat, open, lift the fat, see the cochlear implant and push the fat back. You can additionally put some fat more. So that remains, that option always remains viable in subtotal petrosectomy and implantation. So for interiorization again, these are the three prerequisites. One should go in for interiorization only when these three things are fulfilled. And that too intraoperatively as a final decision. Functioning eustachian tube, mucosal preservation and counseling for the second look. Now what happens sometimes, preoperatively you get biased. Like this patient, I am preoperatively biased for the interiorization, This is an atic cholesteatoma with good intact mesotympanum, air-filled cavity of the mesotympanum. This gives me a good indication that the eustachian tube is good functioning. And I'm biased towards interiorization. We counsel the patient with this technique. You may have to be in long-term follow-up, more than 10 years even. And then the final decision again will be taken intraoperatively. When I remove the cholesteatoma, preserving the mucosa intact, then only I'll commit to this technique of interiorization. And here my entire goal because I am biased towards interiorization because of the good use taken tube function. Had this cavity been having a patient been having a plastered middle ear mucosa, I would have been biased toward exteriorization, looking at the faulty use taken tube function. But here I am biased towards a good use taken tube function. So now I am going to remove the cholesteatoma with utmost care, preserving the mucosa, maximum mucosa intact. And if I am happen to do that, I will do an interiorization. This is the goal today. So this is the indication for interiorization. Then there are certain maneuvers, intraoperatively, by means of which you can improve your outcomes of interiorization. To facilitate mucosalization, to facilitate aeration, like suppose in the process of removal of the disease, you happen to remove a part of canal wall. Suppose a lot of people criticize that this technique is not good for a extensive cholesteatoma. If in order to remove the extensive cholesteatoma, I happen to remove the part of the canal wall, I will not mind it. At the end of the surgery, if I have happened to preserve the mucosa well, if my use taken tube function is well, I will reconstruct the canal wall. So there are certain procedures, adjuvant things which can improve your outcome, like repair the bony defects of the canal wall. There are certain mucosal defects. To improve that epithelialization, I can use silastic or nowadays, gel film. In certain areas where the removal of the mucosa is difficult, and you cannot leave it, you can take the help of laser. Like around the ossicle, over the oval window in certain areas, and you can take the help of laser without, destabilizing anything. You can take the help of endoscope to make sure that nothing is left behind. If you have a doubtful question of ventilation, in spite of a good aeration, if you still have a doubt in mind, you can use the ventilation tube at the same time to prevent ventilation issues coming. And second look is most important. That is something you need to counsel the patient. So in follow-up, what is required? A second look. Now in this present era, we have more weapons except the second look, so that we can avoid second look sometimes. Like we can use the endoscope to see inside. You can use angle endoscope to look into the corners. With a small incision, I can put my endoscope behind in the mastoid cavity and see if there is any cholesteatoma coming. Okay? This way, many of the times, you can avoid, a formal second look procedure. Secondly, with the advancement in the imaging, and particularly this non-ecoplanar diffusion weighted MRI, you can, to certain extent, up to 95% sensitivity, you can diagnose the cholesteatoma. I will show that in this next session. We got the diffusion weighted MRI done, and you can diagnose the cholesteatoma without the need of second look or an endoscopy even. So, after the interiorization, these are all the weapons in your basket for the follow-up. In case second look you want to avoid, you can take the help of either endoscope or non-ecoplanar MRI.
Sorry, Satish, bringing in my atresia again. This is what you had advised me for cholesteatoma in atresia patients.
Yeah.
To rule out the same non-planar diffusion weighted MRI, correct?
Yes, sir. For any cavity. Like this subtotal petrosectomy obliteration we'll do today. This should be followed with diffusion weighted MRI only.
Yeah.
In a slightest indication of developing cholesteatoma, you are picking up with that, you can take a call to explore. Otherwise, you can keep following that up. That is quite sensitive, and I will show that on my DVD. We have next patient's, picture. So
in atresia patients, you make sure that there is no cholesteatoma preoperatively when they present.
Yeah, you can use that diffusion weighted
MRI.
That
is the imaging study to be done.
Yes.
Yeah, thanks.
So now, coming to the exteriorization, why this exteriorization technique is blamed to be a worse technique than intact canal? It's not worse. It's amazing technique. The fault lies in the surgical steps, and if the surgical execution is good, this is equally good. It's equally amazing technique, and these are the reasons, possible reasons for persistent discharging cavity. Like incomplete exenteration. You see the cavity in these pictures, these two pictures on the right side. This is the kind of condition of the cavity, and then you blame the procedure. is something never acceptable. The next case, subtotal petrojectomy, we are taking has been operated 4 times. And you see the state of the cavity after 4 surgeries. That so poor execution of the surgical procedure, you can't blame the technique. So here, there are many regions in the canal down, incomplete exenteration. Ashish, is Ashim there? Ashish?
He's not there.
Okay. So like inadequate meatoplasty, all these reasons we all know for the failure of the mastoid cavity. Inadequate lowering the facial ridge, and you will find in that next case, all these regions there in spite of 4 surgeries. All these regions mentioned are there to give a persistent discharging cavity. So, this is the third technique which we follow. Problem cavities, multiple surgeries. When the patient has because of the previous surgery, large tegment defect leading to brain herniation, you have to obliterate the cavity for prevention of future infections, future meningitis. If you have happened to expose the critical structures like dura, sinus, carotid artery, better to obliterate for future, provided there is no possibility of hearing reconstruction in future. Then only, because after multiple procedures for such cavities, after multiple surgery, their hearing level goes down. They develop sensory neural loss also, and they have even full conductive loss with no possibility of reconstruction also. And we have number of indications. This is one of the favorite procedures in our practice. We get a lot of revisions, subtotal petrojectomy, and this gives patient a big relief for a permanent cure to the ear discharge. And it keeps the possibility viable for reconstruction of the hearing by means of cochlear implantation in the future. By means of Baha, if it is a conductive component, you can still put a Baha any time in the future. So this doesn't, take away that possibility. And then petrous bone cholesteatoma, deep petrous bone cholesteatoma, we'll be keeping in the coming webinar some of the cases of deeply invaded petrous bone cholesteatoma, and that is where you need to obliterate the cavities for the future infections, for prevention of future infections. So, how to decide? We discussed so much of things, still the confusion remains in what patient what to do. So these are certain factors which you need to take into consideration before taking a final call on interiorization or exteriorization. In between them, there are certain good techniques. Like I tell you, one of the techniques is soft wall reconstruction. People have given different name to the sum of the variation of the technique. And one of the soft wall reconstruction, we had a demonstration last time by, Sudeep Munjal from Sirsa, who demonstrated soft wall reconstruction. And that is a technique propagated by our own Dr. Suri Prabhu. So what he does, that's a very interesting. Suppose you have exteriorized the cavity. You cannot exenterate each and every cell in the labyrinthine region around the semicircular canal. What you can do? You can include that area in the middle ear cavity, and rest of the cavity behind you can obliterate. Got my point? So you can include that by means of reconstructing a soft wall over that. Rather than a rigid wall, you can reconstruct and cover that with the cartilage and include in the middle ear cavity, so that the aeration remains to the remaining cells in that region, which you cannot remove otherwise. And that is what soft wall reconstruction. So there are in between so many techniques which are good, and people are taking into consideration for those particular situations. But we cannot be biased towards one technique. So these are the decision-making factors that you need to take into consideration, that what technique to be chosen in what situation. For example, the number one thing which is prevailing worldwide, is what? Surgeon's preference. I do intact canal. I love intact canal. Intact canal is best. It is all surgeon's preference by different means. And this is something which is prevailing over the world, overall in the world, not the science. You have to be out of the dogmatic approach. Anybody who is sticking to some particular technique, no other technique is bad. All techniques are good. We have to be able to choose according to the situation. So like, For example, how, see, final decision is intraoperatively, but there are certain situations it makes you biased and you can take a call accordingly. Like patients in whom regular follow-up for the mastoid wall cannot be assured, you get biased towards a canal down so that you don't need a second look operation. Or patients who don't want to go repeated surgery. Some patients tell you, do in one time, I will not come back for I don't want any operation in my life. You know, the patient preference is the final thing. And then you better go ahead and do a canal wall down or exteriorization, but execute it properly. Like in the cholesteatoma, in the facial palsy case we discussed, if there is a cavity, don't leave the raw areas. You cover with the vascularized tissue to promote epithelialization. If you leave a lot of raw areas, that will invite osteitis, discharge, and such cavities many a time become lifetime draining cavities. So a poor execution is something to be avoided, to avoid blaming the technique. Hearing is a factor sometimes. If you are operating on a only hearing ear, you're always, biased towards something, a final solution for that particular. In the sense, for a solution that will not require surgery again and again. Because every ear surgery, every time you do ear surgery, has a potential to give sensorineural hearing loss. So in only hearing ear situation, you're always looking for a technique which doesn't require a revision, and that is what the canal down is. Because every time in a intact canal, you may have to revise the procedure, you may have to go for a second look, and any inadvertent ossicular movement, drilling, anything can lead to sensorineural hearing loss. So better is to do a once for all canal down. This is a very strong bias towards a canal down in only hearing ear. But now it is changing in the present era. I remember the question in the last year, when Kirtne sir organized a panel in Jaipur on stapes surgery, and he asked Ashish Bhumkar, in only hearing ear, would you do stapes surgery? He said, yes. If it was a dead ear, so what? We'll do implant. So now, the time is changing. Because that incidence of giving a dead ear in the only hearing ear by an experienced person is 1 in 100. So he said, I will do one implant free if I get 100 patients of only hearing aid stapes surgery. Still, I am happy about it. So the time is changing because you can restore the hearing by means of a available technique of cochlear implantation. So in the only hearing ear only, even in that situation with the advancement in the radiology, with the extent of disease, advancement in the surgical technique, advancement in the cochlear implant and all, a lot of people are changing even to a good reconstruction if the eustachian tube function and mucosa is available, to an intact canal technique. Otherwise, there is a strong bias towards a canal down technique. Eustachian tube function, nasal issues, slightest doubt, canal down. Don't take a chance for a revision. You don't want revision, but once you are thinking that it leads to a possibility of a revision, why to take a chance unnecessarily? So that is something, again, gives you a bias. Small sclerotic mastoid, like we did on Thursday. Like we did on Thursday, we were biased towards a canal down because ultimately we know we are not going to give a cavity problem as the cavity is being very small. Pediatric, elderly, high risk, you have to take call accordingly. See, these are the factors you need to see where your patient is falling into. Pediatric, I said we are in a bias of interiorization to give them hearing and prevent the cavity issues, because they are not going to follow rigorously the cavity cleaning and all that. Elderly, we are biased towards once for all, canal down, that's it. Because they may not be fit for surgery again and again in their lifetime. So do once and get away. So there are certain biases we need to. High risk patient, just one surgery, canal down. So you may not get a chance to revise it. You may not get the patient fitness again. Sometimes cholesteatoma is going in the eustachian tube. That is the situation where you can't think of any kind of reconstruction, because that may not give you opportunity, may lead to eustachian tube fibrosis and all that closer. So there are certain situations like hidden areas, aggressive disease, exposure of vital structures, I told you, it keeps you biased towards exteriorization, or if the hearing is gone, towards the subtotal petrojectomy. Labyrinthine fistula is most interesting. Still it is a debate what to do. So you have to take into consideration many factors. If you are finally committed to a interiorization and there is a labyrinthine fistula, come to the fistula in the end after completing everything and take a call. If it is a small fistula and you can peel off the skin, fine. If your procedure is curative in one stage, what you have done, intake canal, you remove it, fistula, gently and close it, preserving the hearing. If it is a big fistula, then you have to take a call for a second stage. Until then, the epithelial pulp will form and you will be in position to better remove it. If you are committed to an exteriorization, leave the epithelium over it and be a part of the cavity. Then it is so simple. So fistulas are again complex to take a call. You know, it is your intraoperative decision what to do. Pre-operative imaging has changed the scenario now. Because now you get a lot of information pre-op for the decision making. You get information of the labyrinthine fistula pre-op, you get information of the status of the tagman, status of the exposure of the vital structures, status of the labyrinthine fistula, everything you get to know pre-op. So now the decision making has become more easier, you are more biased, you are more prepared pre-op what to do it down or up by means of imaging, because imaging has totally revolutionized. And recurrent disease and complication again makes you biased for a canal down. Like suppose we have done a canal up earlier, interiorization, and the patient eustachian tube function ultimately didn't do well, and patient is coming back after a year or two with the same retraction, you know, cholesteatoma. Then there is you don't have to think twice to exteriorize it. But if somebody else has done and you find intraoperatively that the earlier procedure was not properly executed and still a possibility to, you know, reconstruct it, you can take a chance. Taking the patient into counseling, into confidence, then you can take a call even for the interiorization. So these are the various factors, decision-making factors. Each and every is important and you have to take into consideration thoroughly before taking a call, and that too intraoperatively for a final call of interiorization or exteriorization. It cannot work that I have been doing for 10 years exteriorization and I am good at it and I will do that only, intake canal is bad. Or I am doing intake canal for years. That is a pure dogmatic approach. That is pure non-scientific approach. And there is no place in science for such approach. Pediatric, I mentioned already, pediatric are, you know, yeah, pediatric are different pathology. In pediatric, you have to take a, you have to be, or you are biased towards the interiorization, but not 100%. It is the final decision on the table what to do. So finally, what would I say? Both are good techniques. Technique is never to blame. Choosing the right technique is most important. And once you choose the right technique, execution of the right technique, surgical procedure is more important. And for every patient, it is an individualized decision, and that too on the table. This is my submission before we move on to the case. We can take questions or your opinion. Surendra sir, your opinion?
Yeah, Satish, I think I would, in certain situations, I will have my preferences. For example, as you correctly said, when there is a grade 4 atelectasis according to SADE classification, or grade 5 for that matter, then it is not compatible with intact canal wall. You have to bring down the canal wall. That is my concept. Then profession. Suppose someone is a swimmer. Then possibly intact canal wall approach will be a better option, or canal wall up technique. Also, the kind of cholesteatoma that you have. Certain cholesteatomas, they grow in, like, you know, they still have a very well-defined sac. So when I open the mastoid and I see it's a very well-defined sac and I can deliver it nicely through the editors and down, and then combine it with the anterior approach, then I will be inclined to continue with the canal wall up technique. One point I want to ask you, how would you, suppose there is a dura exposure
Yes, sir.
significant dura exposure someone is doing. In that case, would you be better placed in keeping the canal wall up, or you would like to bring the canal wall down to avoid future infections?
Yeah. So first of all, I will take the same things in consideration. Eustache and tube function. Eustache and tube function, availability of the mucosa. If that gives me relief that I can reconstruct,
Yes.
I will certainly interiorize, and why to expose that exposed dura and everything to the exterior. But yes, if there is a slightest of doubt in, the existence of the reconstruction, I will not think twice, do exteriorization and cover those areas, exposed areas like dura or sinus with the vascularized flap to prevent infection.
Okay.
Any questions? Meantime, we can take, before I take you to the radiology of this patient.
No, ji, because we are waiting for the radiology. Yeah.
Any questions, boss?
No, I think it's almost been covered. They wanted to ask about the pediatric, which is the earliest age you would recommend for the canal wall down, or you can exteriorize him. What is the earliest age?
To me, this question doesn't exist. It is always an intraoperative decision.
Yes, yes.
You cannot be biased.
All the things been covered so far.
So, there is always an unnecessary discussion going on which technique is good and which technique is bad. This question doesn't exist to me. All techniques are good, provided how you execute it and for right indication or not.
But I think Satish Pachauri is asking at what age you will take patient for surgery, minimum age.
If cholesteatoma is there, then age is no bar.
Okay.
See, we have removed cholesteatoma in 4-year-old child. How can you ignore cholesteatoma? Age is no bar. It is not central perforation or something tubotympanic you can wait for.
Any queries about the tube function, how you assess the functioning of the issuing tube? I think mentioned told many times.
Yes. Eustache and tube, like in this patient, I will show you the picture. That itself shows that Eustache and tube is good. Otherwise, particularly in pediatric patient, the incidence of otitis media, incidence of Eustache and tube issues, incidence of nasal problems are high. And you always have to keep an eye on the nose of the patient. Even post-operative, even if you operate, you have to keep an eye on the nose of the patient to prevent allergy, infection, sinusitis, adenoids, ruining what you have done. So in pediatric patient, this is most important. Rather, before taking up the patient for surgery, you have to thoroughly see the nose and fix the nose first before coming onto the ear. That is the right dictum, 100-year-old dictum. And it works well in the pediatric patient because pediatrics have a high incidence of, adenoids and other issues, resulting into malfunction of the Eustache tube. And if we ignore that, you cannot ensure a good, reconstruction of the ear.
Satish?
Yes, sir.
Hello, Satish sir.
Yes.
Hello.
हाँ जी, madam.
Sir, if concomitant pathology in the nose and throat is there, so first you would like to deal those problems, and then you will go for the cholesteatoma surgery, or
Yeah. If it is something need to be treated. If nose is significant, nose is having something significant, need to be treated, which has an impact on the Eustache tube function, that has to be addressed first.
So if patient is a huge adenoid, then first you have to remove the adenoid.
Yes, you have to. They may be having associated allergy also. Allergy is a big factor.
Okay.
Allergy, adenoids, otitis media with diffusion, Eustache tube, they are all interrelated issues. So you have to break that cycle. You have to address the adenoids, allergy, and improve the function of the Eustache tube before directly impinging on the ear.
Satish?
Yes, sir.
But you cannot, see, your classification is really excellent. It simplifies a lot of misconceptions. Regarding the children, adenoid is a very straightaway correctable thing.
Yes.
There are many nasal conditions in children which possibly after adenoidectomy might improve. But there are certain conditions which will not improve, like allergy. They are always catarrhal children. In those cases, I think the treatment should go parallel, and cholesteatoma still has to be addressed.
Cholesteatoma cannot ignore.
Yes.
You cannot ignore for long.
Sometimes we do give extra significance to deviated septums. I don't think deviated septums, unless they are causing sinusitis, they by itself can cause eustachian tube dysfunctions. And you should not try to just keep doing surgery for doing septoplasty, and then later on by that time the patient is already fed up by nasal treatment, and then he just goes away.
Yes, absolutely.
So that has to be very judicious judgment.
But there are certain group of patients where again we are biased, like cleft palate patients.
Yes.
Cleft palate patients have inherent eustachian tube malfunction majority of the times.
Absolutely.
Because of the muscles, dealing with the eustachian tube, controlling the eustachian tubes are affected. And in those patients, you have to be careful. Doing interiorization in those patients can be troublesome sometime because of the question mark eustachian tube function. So again, those are the conditions which makes you biased towards exteriorization for one-time procedure.
Yes.
Tube closer, external tube block means closer. Like your student Nitesh Ore is asking, a situation where the cholesteatoma is in a contracted mastoid, the exposure of the posterior fossa dura and tegmen is eroded, and the tube is congenitally blocked because of bony defect. How would you proceed in this case?
Subtotal petrosectomy. That's it. It itself answers. You have a contracted mastoid, you have a tegmen exposed, dura exposed, eustachian tube, no function of eustachian tube, no question of hearing reconstruction by any means, and your structures are exposed to give complications already. Give him one-time solution of preventing discharge and preventing complications for future. And you can give him a BAHA if a conductive hearing loss is, or if it is sensory neural, you can give other things, and that is all the options are viable. Because once hearing reconstruction is not possible, you have to ablate it. That's it. At least give him a dry ear and prevent complications for future.
Yes.
Satish bhai, if patient is having very good dry ear, good healed cavity, and he comes 6 monthly for removal of wax, and when we do the suction, he is having very severe vertigo that he is afraid of. For those patients, for this vertigo, we can do anything?
Yes, you can. First of all, you can reconstruct the cavity better by putting some soft tissue bone dust and reconstruct the mastoid. Simply reconstruction of little bit of the mastoid can save you from big problem. And secondly, if nothing works, I told you, there is a final answer for everything. You can obliterate the mastoid if you have a, a good epithelialized mastoid, good exteriorization and saucerization of the cells done. Elevate the epithelium and obliterate the mastoid completely and reconstruct the posterior canal wall. If it is a good functioning middle ear, you can reconstruct the posterior canal wall and obliterate the mastoid. So there are so many procedures in between, to save from such problems. And if nothing is reconstructible, subtotal petrosectomy, obliteration.
One good point by Dr. Girish from Bhilai. Can we do adenoid with the cholesteatoma or CSOM or septoplasty with CSOM in same sitting?
Yes, adenoidectomy you can do for same sitting. Secondly, the septoplasty doesn't have a direct relationship with the outcome. Having a septal deviation is not an indication for surgery always, and it has no direct impact on the outcome of the ear surgery at all. Adenoidectomy can have, because it has an effect on the overall mucociliary clearance. It can precipitate towards, eustachian tube dysfunction. It can precipitate towards sinusitis, and it can affect the overall mucociliary activity. That is something justifiable, but not septoplasty. And that you can do same sitting.
Two people asked, one was septoplasty with mastoid, he asked about adenoid and mastoid. I just combined together.
Pardon?
One person asked about the septoplasty and CSOM, and he asked about adenoid with septoplasty with CSOM. So I just combined both the questions.
Yeah.
We can do we should not do septoplasty, but we can go for adenoid with
yes.
CSOM.
Yes. Absolutely.
Can we start radiology now?
Pardon?
Radiology now.
Okay.
What is called-
Okay. So, we have discussed the CT scan of the temporal bone radiology in perspective of otosclerosis and stapes surgery. We have discussed in reference to cochlear implantation. Now this is different perspective. What all need to be seen on radiology in perspective of chronic suppurative otitis media surgery. This is altogether different what we are going to look at now. So CT scan has to be seen differently for different pathologies. Here, like we discussed so many factors, we will touch upon only those issues which have the impact on the surgical outcome, which have the impact on decision making, which have the impact on choosing the particular surgical technique, and which can make your surgery difficult or which can lead to complications. All these factors, all these things to be seen now differently in this CT scan. Now, first of all, coming from above down. First important thing I would always point out here, to see the pneumatization of the mastoid. See this, overall temporal bone. This has a significant impact, and this pneumatization has to be gauged by three ways. There is a clear-cut way of ascertaining whether this temporal bone is hyperpneumatized, hyponeumatized or not. So, to me, this temporal bone is hyperpneumatized. See this, extensive pneumatization. There are three parameters. Number one, this is the sigmoid sinus. Can you see? This is the sigmoid sinus. This pneumatization, which is extending up to the anterior wall of the sigmoid, up to the posterior wall of the sigmoid, or even beyond the posterior wall of the sigmoid. See, it is going beyond the posterior wall of the sigmoid. See how extensively it is pneumatized, number one. Second parameter of pneumatization is come from above. See, this is superior canal. This is the petrous bone going towards the clivus. Here is the superior semicircular canal labyrinth. And see how much of the pneumatization is there anterior to it. It is pneumatized, and that is significant pneumatization of the petrous apex as well. And third definition is, it has a significant impact. Third is, pneumatization you need to see in the coronal plane. See this. What is there? See the cochlea and the vestibule. See, this is cochlea vestibule, this is intra-auditory meatus. And you see deep to this anteriorly. This is extensively pneumatized on both sides. So what it has an impact? How it is important? In case you are doing an exteriorization, you need to extensively drill away all these cellularity. Otherwise, it will remain a permanent discharging ear if you leave that much of mucosa behind. And what does it mean? It means such an ear, we are biased towards interiorization. Just remove the disease and make sure the rest of the cells are, ventilated down the eustachian tube for the good function.
Point.
Yeah. So now we are looking at the CT scan differently. So number one is pneumatization. Number two, like sir mentioned, how is your tegmen plate, how is your sinus plate, whether they are affected by the disease, exposed, or disease going beyond that, or anything like that. Sometimes we get asymptomatic, perisinus abscess, extradural abscess, so many things. So this is your sinus. This is your sinus, sigmoid sinus, all the way, all the way, all the way, right from up, right from up, right from up till, see this, up to down completely. This is jugular bulb. So this plate is completely intact all the way you can see. Can you see?
Yeah.
Now how to see the tegmen? We didn't see all these tegmen and all in otosclerosis, in CI and all. That has hardly any relevance. But here it is. So now here lot of things to be seen in the tegmen. I'll give you a classical example of this. Why it is so important. See, this is tegmen plate all the way. This is your mastoid and this is the tegmen entri and this is tegmen tympani. Why so? At this level, see, I am going from anterior to posterior. This is coronal section. Here at the level of the cochlea, this is all lateral to medial. What is this? Tegmen tympani. Okay? Yeah. Now, if I go behind, at the level of, these are semicircular canal, see this. If I go behind, at the level of semicircular canal, what you see, this is lateral, this is medial. What is this? Tegmen entri. This curvature of the tegmen from lateral to medial has a significant bearing.
Yes.
I remember one of the patient, a surgeon, not knowing the importance of the tegmen curvature, ultimately led to facial palsy. And that was a disaster. We revised that. How come? This tegmen laterally, see, many of the patients, this is not too much of curvature. If laterally, this is lateral, this is medial, at the level of the semicircular canal. If this lateral tegmen is quite low, got my point? And medially tegmen, many a times you see high up. That means when you start drilling laterally, your tegmen is quite low. That pushes your direction of drilling below. Got my point? And that doctor, by mistake, that was doing an antrostomy to look for the antrum, was biased by this tegmen which was directed, which was quite below, laterally. Kept on following the tegmen below and ultimately damaged the facial nerve. The actually antrum was medially quite up because the tegmen curvature was taking the antrum high up. So we need to see in every case the curvature of the tegmen, that is very important. If laterally the tegmen is low or medially tegmen is low, medially is high, laterally low, all these things have to be kept in mind once you start drilling for the mastoid. Got my point? To prevent complications, number one. Number two, how much your tegmen is low or high. How do you ascertain? See in the coronal picture. This is my lateral semicircular canal. Can you see?
Yes.
And this is tegmen. You can see through this how much is the difference height above that. See, almost 5 to 6 millimeter. So my tegmen is 5 to 6 millimeter above the lateral canal. It is not low-lying tegmen. Got my point? Yeah. My tegmen curvature, height of the mastoid, height of the tegmen, and if there is anywhere tegmen deficient, see, it is all the way intact. If there is anything like brain tissue prolapsing or anything, how much the size of the defect, you can see on this coronal section. So this is something important in the CSOM case. I am just taking to the radiology in perspective of CSOM. Not as a whole, I am showing, discussing the CT scan of the temporal bone. So that is one important thing. Again, after the tegmen, sinus, third important thing is the facial nerve. See, in CSOM surgery, in cholesteatoma, particularly here in the cholesteatoma in the attic, you have to be concerned about the exposure of the facial nerve because the facial nerve may be exposed, may be compressed, may be dehiscent, or may be intact. Knowing the state of the facial nerve make your surgical course much simpler, much better. It can, make you suspicious of a probable facial nerve dehiscent. You have to be careful about that. So here, see this again. That is the intra-auditory meatus. That is the facial nerve going here. Can you see?
Yes. Yes.
And the same thing, this side. See on the disease side. This is interesting. See, this is the facial nerve. This is the geniculate ganglion. Let me change the contrast to show you better. See the geniculate ganglion?
Yes.
And see the facial nerve. See, my cursor is on facial nerve. This is the second genu of the facial nerve. Can you see?
Yes.
This is the second genu of the facial nerve. See I'm keeping an eye on the facial nerve. See my cursor, where is?
Yeah.
That is the facial nerve. That is how you have to look at the facial nerve. And see here in the mastoid, there is a lot of thick bone over the face. This is lateral. The thick bone lateral to the facial nerve. That is ample of height of the facial ridge. The bone of the posterior canal is not deficient. Facial nerve is deep in the place. And here, following this, but in the tympanic segment. See, now I am going towards the tympanic segment here. Here the facial nerve is probably dehiscent here. Can you see this?
Yeah.
This opacity, you cannot differentiate whether it is a granulation, cholesteatoma, fluid, mucosa on CT scan. You can differentiate on MRI findings, on the basis of MRI findings. But on CT scan, you cannot differentiate the opacity. But what all you can see here is the facial nerve is dehiscent in the tympanic segment. Can you see this?
Yeah.
Very clear. In contrast, whenever you have a doubt, go to the opposite side, normal side, and see. See the facial nerve here? See the facial nerve here? See the facial nerve. Can you see very clear? See the facial nerve all the way. Such a good facial nerve. No disease, no dehiscence. And this is normal facial nerve. See this bony covering of the facial nerve all the time. See this bony covering of the tympanic segment completely.
Yes.
And here on this side, it is completely, at places, it looks dehiscent. See this is dehiscent. So third important thing is the facial nerve. Now next, obviously we have to see at the labyrinth if there is any fistula.
Little canal fistula just
In
so
extensive, pardon?
Little canal fistula just so
Yes.
exactly where we...
Yes. So you have to see.
What was the complaints of the patient?
Complaint of the patient is a hearing loss and
Patient
recurrent
have
discharge.
vertigo or
Not really. Hearing loss and discharge. Hearing loss,
vertigo.
no vertigo. Now see, next thing is we need to see the labyrinth if it is eroded by cholesteatoma. Cholesteatoma has a property to erode the bone. For bone destruction by enzymatic and by contact, by pressure, so many things. So we need to see if the cholesteatoma has destroyed any part of the inner ear. We are looking at the CT scan, I am telling again and again, in perspective of the CSOM only. So here, what part of the labyrinth? We need to see the cochlea, number one. See, completely intact.
Yeah.
See the lateral wall, this is promontory. Completely intact, normal. Now see the vestibule, completely intact. And for the semicircular canal, see this lateral canal, follow this. See this? Completely intact. Yes. See compare with the opposite side, see the lateral canal. See this? Follow this dynamically, it's an intact bone everywhere. See this? Similar cochlea. For the best view of the semicircular canal, we have to go to the sagittal. I have shown you earlier as well. And here it is important to rule out, the semicircular canal fistula, inner ear fistula. Now see here, one by one. This is your vestibule. This is your superior canal. See this? Intact?
Yes.
This is your lateral canal. See this lateral canal. See this lateral canal all the way intact. All the way, complete circumference. There's a thick bone all the way around. And similarly, if you go behind, this is the posterior canal. And see, it is joining the superior canal to form crus commune. And it is completely intact. So there is no labyrinthine fistula, you can say. We have seen Tagman, we have seen Dura, we have seen pneumatization, we have seen facial nerve, and we have seen the labyrinthine fistulas. Now the next thing is, though it is not important here, that is important in on MRI, if the cholesteatoma is extending anywhere beyond the middle ear cleft, because here you cannot differentiate between the cholesteatoma and the opacity. Now the dehiscence of the surrounding structure, jugular bulb, see this, jugular bulb absolutely intact here, carotid artery absolutely intact, In the deep petrous bone cholesteatomas, these structures many a times you will find dehiscent. I told you we are going to keep very soon a case of petrous bone cholesteatoma where you will find all the entire petrous bone is invaded by the cholesteatoma and making all these structures at risk. And you can evaluate that on the CT scan. Now, another important thing is the status of the ossicles. How can you see? See, first of all, go to the opposite side. Can you see the malleus and the incus?
Yeah.
Malleus, incus, and see how it is coming to the stapes here. See, this is stapes, this is vestibule. This is vestibule, this is foot plate. This is foot plate, this is suprastructure. This is long process of the incus. Could you see that?
Yes.
Malleus, this is malleus head, this is incus body, long process, and this is stapes. Intact. Now look at this side. Look at this side. This is the level of the ossicular chain. What you see, some part of the malleus head, can you see?
Yes.
Some part of the incus body, can you see? But no communication beyond that. No communication beyond that towards the suprastructure. I see some faint structure looking like suprastructure, but I don't see any communication with the incus. See here.
Yeah. Yes, yes.
Not very sure. And this is all completely opacified.
Yeah.
So the status of the ossicles, status of the middle ear, and next important thing is the sinus tympani. See, how can you see sinus tympani? See this. Go to the opposite side first. This is facial now. This is cochlear, round window. See, this is round window. This is facial now, and medial to the facial now, this air space is sinus tympani. Can you see? The same thing if you go here. This is your, see, facial now.
Yes.
Going up, going up, going up, facial now, facial now, facial now, facial now. This is your sinus tympani. Can you see the opacity?
Yes, yes.
This is the round window, this is sinus tympani, and this is,
Facial.
facial now, and this is opacity. Now, you cannot differentiate whether it is cholesteatoma or granulation, secretion, hypertrophic mucosa or whatever.
Yeah.
You cannot differentiate. So,
Yes, yes.
in CSOM disease, these are the important points that need to be seen in every patient before you going for cholesteatoma surgery. These are not required. It is not essentially required in, central perforations. But in cholesteatoma, if you have a CT scan, it gives you a lot of anatomical details, lot of factors important in decision making. And if you ask me, I always recommend a CT scan for cholesteatoma. It is always good to have. It is not something like guidelines. It is mandatory, but it is something definitely which has a huge impact on the decision making.
Satish, one point I wanted to make here is that you should also mention the degree of petrous apex pneumatization.
I have already mentioned, boss. I have already mentioned.
Because that will be very, very important for deciding what sort of cavity you want to give during the surgery.
Yes.
Yeah.
See this, I mentioned in the beginning. I think you were not there that time. This is the level of the petrous apex, that's the level of the superior canal, and see the pneumatization medial to it.
Absolutely.
Secondly, the infracochlear pneumatization. I mentioned that. See this infracochlear pneumatization, because if you are doing exteriorization, you have to look at this first, whether you will be able to do. See, this is cochlea. This is cochlea.
Yes.
This is, the intra-auditory meatus. And see this huge pneumatization going anteriorly towards the petrous apex. This is petrous apex.
Yeah.
This is apex of the petrous bone, and see the huge pneumatization extending to this.
No, the clinical implication would be when you need to do a reconstruction, a partial reconstruction to aerate that area down the station.
Yes. So here I am biased towards performing an interiorization.
Exactly.
Because if I exteriorize, I need to excentrate every possible cell, and which is so difficult in such extensively pneumatized, petrous apex. It is, next to impossible if you try to do that. And in that situation, if you are not able to do and do an exteriorization, it may become a permanently discharging cavity. So this concept of pneumatization ascertaining is very, very important. Now, I mentioned in the beginning, these are different cuts. If you want to see in this particular patient, see the facial now.
Beautiful.
This side. See, this is the superior canal view, and this is the facial now on this side. See, in spite of that much disease here, this is the vertical segment completely intact, genuine, and the tympanic segment here is showing dehiscence. That's what I was predicting. Yes. See that? So that's how you can reconstruct. Now the most important thing in cholesteatoma, in such diffuse middle ear opacification on CT scan, what is the differential diagnosis? It could be a hypertrophic mucosa granulation. It could be, empyema, fluid. It could be cholesteatoma. It could be cholesterol granuloma. It could be some tumor. How to differentiate? There are certain sequences of MRI by means of which you can differentiate them all. What are those? See this. T2. First, I'll take you to the most important T2 sequence. Here. This is T2 drive sequence, 3D. What you see here? Everywhere bright appearance. See that? All secretion, cholesteatoma, everything appear bright. Now, how can you differentiate whether it is cholesteatoma or granulation? Or could be cholesterol granuloma? How you can differentiate? At the same time, I will bring in, at the same level, another sequence. See this. T1 weighted. Now, if something which is hyper intense on T2 and which is hyper intense, suppose this is not hyper intense. If it is hyper intense on T1 also, then it is surely cholesterol granuloma. Got my point?
Yes.
If something is hyper intense on T1 and hyper intense on T2 also, it is cholesterol granuloma, which is not here. This is not hyper intense on T1 also. This is hyper intense on T2 only. See this? Now, if something is hyper intense on T2 and enhances on contrast, what will be that? Either inflammation or tumor. Tumor also, see this. Here, this is the contrast. Now see, it is hyper intense on T2 and hyper intense on contrast also, because the inflammation also takes some contrast because of high vascularity. But this rules out empyema. Had this been empyema, secretion, fluid, it will not enhance. I am showing how to do differential diagnosis on MRI.
Yes, yes.
Now, this could be hyperintense mucosa secretions, cholesteatoma, but the cholesteatoma will not enhance. Now see, that is important. At this point of time, you have to answer. See this. This is enhancing, this is secretion. This is the area of the cholesteatoma, what I mean to say here, which is not enhancing. Can you see this dark? Completely dark. That is not something which is not enhancing, that could be cholesteatoma. How can you differentiate 100%? Now I will bring in diffusion weighted. Diffusion weighted will make plus or minus everything clear, crystal clear. Let me bring in. Yes. See this. On diffusion weighted, the cholesteatoma will appear hyper intense. Can you see this? Can you see this?
Yes, yes.
This is the level where it is hyper intense, and that is cholesteatoma. See in this is the mastoid level. At the same level, whatever appearing hyper intense on diffusion is cholesteatoma, and if I get the diffusion coefficient, it will be dark. And that is classical of cholesteatoma. See, on diffusion weighted MRI, I am not going in here in detail. If you want, I can tell you this is cholesteatoma. Cholesteatoma is a cellularity. It gives restriction on diffusion. So on ADC mapping, it will appear dark. And that is characteristic of cholesteatoma. It will not enhance. It will have diffusion restriction. It will not be T1 hyperintense. It cannot be anything else than cholesteatoma. As simple as that. So by taking into consideration all these sequence, you can do a differential diagnosis of all possible lesions inside the temporal bone. That's why MRI is the choice for soft tissues. Bone, for the bones, CT scan is the investigation of choice. For soft tissues, MRI is the investigation of choice because of the versatility of the MRI, because of giving so many sequences. That is how you can diagnose. So before we move on to the case, any questions?
Perfect.
Very nice.
So we have already discussed the decision making, and in this patient we are biased towards interiorization for the reasons I told you, for the pneumatization of the temporal bone, for the status of the Eustachian tube. Both are making me biased towards interiorization. Out of all these factors, two most important factors which are making me biased towards interiorization. I will do interiorization only now, finally, on the table decision, if I am able to preserve good amount of mucosa for the diffusion, gaseous diffusion. If I happen to remove all mucosa while removing the disease, there is no point in interiorization. Even if the Eustachian tube is intact, even if you do intact canal, the air is coming through the Eustachian tube, but no mucosa in the middle mastoid. Where will the gas exchange take place? That will lead to negative pressure, and that the whatever operation you do is going to be a certain failure. And then we blame the intact canal as a procedure is a bad procedure. It is not a bad procedure. If you are committing to the intact canal, you have to preserve the mucosa. So whatever gas coming to the Eustachian tube will get exchanged at the mucosal level and keep the middle ear healthy. So, do we move on to the surgical part?
Yes, yes. People are waiting for that.
Subirendra sir, anything you want to add on?
Yes, absolutely. Very nice.
Very often we get cases with the necrotic cholesteatoma with the post-oral sinus or fistula and with the foul smelling. Any different protocol for those cases? You go for any preoperative other investigation, culture sensitivity, and how you reconstruct everything that those cases? Do you do reconstruction of those cases because they have a very large cavity?
Bigger, I mean the post-oral fistulas, extensive cholesteatomas and all that.
Yeah, yeah.
See, the final decision, there are certain things, extensive disease and all this makes you biased towards exteriorization.
Yeah, open cavity.
But intraoperative is the final decision. If after the removal of the disease, if you find still the Eustachian tube function looks nice, good middle ear, status of the middle ear mucosa is good, and you have left the ample of mucosa, you can reconstruct. Even if you have removed the canal destroyed earlier, whatever happened to the canal doesn't make any difference. The procedure is going to be interiorization. You can reconstruct it. There is hardly anything in reconstruction of the canal in any given situation, provided that your gaseous exchange should take place down the Eustachian tube post-operatively, then only you reconstruct. Otherwise, do exteriorization. So all procedures will be exteriorization, except in the situation when Eustachian tube function and a good mucosa warrants interiorization, otherwise all exteriorization. Now you choose, you assess in your practice how much you can interiorize, how much you can exteriorize. That depends. For every patient, decision is individualized.